So, hi, everybody. I'm Ann Messman. I'm a professor of emergency medicine at Wayne State in Detroit. And we are doing a panel tonight with Dr. Pamela Dine, Dr. Brian Baskin, Dr. David Barnes, and Dr. Andy King about career transitions moving beyond traditional emergency medicine roles. These four have either part-time or full-time stepped away from clinical emergency medicine. And I think a lot of us are very curious about what that looks like and how you make that kind of a transition. I want to give a shout out to Nancy Kwan, who's on the call. She's the fearless leader of the Faculty Development SAEM committee, of which one of our tasks was to create this webinar. Thank you, Nancy, for being here. I'll lead sort of some of the questions for about 45 minutes or so, and then the participants that are watching this webinar, if you have any questions either for the group in general or for a specific person, please feel free to go ahead and put them in the chat, and then we can have kind of open forum towards the end. So I'm going to have the panelists introduce themselves. Dr. Dine.
Good afternoon, everybody. I'm Pam Dine. I'm just really happy to be here with you all. I'm probably a little bit unlike the rest of the panel members in that I have not actually stepped out of academic clinical work in emergency medicine. So I'm a professor of clinical emergency medicine at UCLA and the chief physician wellness officer at Olive View UCLA Medical Center. That's where I currently am. And yeah, that's probably all I need to say right now, right?
Anything you want.
Okay. Okay. Well, it'll all come out later.
Perfect. Perfect. Dr. Barnes.
Thanks so much for giving me this opportunity. I'm looking forward to this. My name is David Barnes. I'm a professor of emergency medicine at University of California at Davis in Sacramento, California. I was program director for the EM residency for almost 12 years until about 3 years ago. Similar to Pam, I haven't stepped away completely from clinical emergency medicine, but about 25% of my time is spent as a physician advisor for UC Davis Health System. So that's given me an opportunity to really go up the ladder, as it were, into a larger, looking at the health system through a lens and a much broader view of inpatient medicine and outpatient referrals and things like that. So looking forward to talking more about that.
Wonderful. Thank you so much. Dr. Baskin.
Good afternoon. My name is Brian Baskin. I'm the Vice Chair of Safety, Quality, and Patient Experience and the Co-Director of Operations for the Department of Emergency Medicine at the Cleveland Clinic in Cleveland, Ohio. And I too am a practicing emergency physician, still practice part-time at a few of our emergency departments throughout the system and hold a assistant professor of emergency medicine through the Lerner College of Case Western Reserve University's School of Medicine. And appreciate the opportunity to come here and speak today.
Thank you. Last but certainly not least, the great Dr. Andy King.
I think I'm the only person that doesn't do any emergency medicine now for over a year. I'm the medical director of the Michigan Poison and Drug Information Center, and then we do a bunch of inpatient addiction medicine service at the Detroit Medical Center and an associate. I'm also right in the Toland Park Research Center, which is a methadone clinic that I direct also.
Awesome. Dr. King, if you don't mind, I'm going to throw the first question at you and then the other panelists can jump in. So what motivated your decision to kind of step away from clinical emergency medicine? Is it career growth, other factors, burnout?
It was kind of getting promoted up. And then when I took the directorship of the Poison Center, it became difficult to be able to maintain working as an emergency physician and then doing all the other administrative tasks, et cetera. And then as I fell in love with addiction medicine, became board certified, and then started working at this methadone program here and found that this is the more rewarding patient population for me to be working with. And so little by little, we started creating the inpatient service that we're currently very busy with right now. And then all of that it scratched the clinical itch just the right way. And so I was able to step away completely from emergency medicine. And I think it's been a year and I'm not counting, but 37 days and 16 hours and 3 minutes since I was last in the ED.
Great. Any of the other panelists want to say what motivated you to not leave emergency medicine completely, but maybe to decrease your clinical footprint?
Yeah, I can speak to that. I still have an itch and a love for emergency medicine. It's just not quite as potent as it was when I first finished medical school. When I transitioned out of the program director role, I found myself wanting for more and just being more inquisitive about parts of healthcare and the healthcare system that I felt insulated from as an emergency physician. And just being curious, I kind of explored what other opportunities there were. And it gave me that opportunity to really get involved in parts of the healthcare system that I'd never really experienced, just living in the emergency department. So my role is kind of upstairs. I work in the managed care world as well, and utilization review. And it's just opened up my eyes to this really intricate and amazing system that I knew existed, but I didn't know anything about it. So for me, it was more kind of curiosity and finding purpose away from the ED.
Yeah, and I can piggyback off those two responses. For me, it was actually just personal interest, and I still have a love of emergency medicine and enjoy practicing it. I actually think it continues to enhance the administrative side of the work I do. But I personally was focused in operations and just always interested in how we can up titrate whatever we're doing in our department or hospital system. And that interest just brought me to projects that brought me to larger groups, that brought me to leadership roles that have naturally progressed over my career so far and have been really fruitful. And I look at it as a way of somewhat multiplying what I do in emergency medicine. So on a given shift, I'll see 20 patients. But the work that I do now in operations and safety and quality specifically, and patient experience, is across 30 EDs in our system, which are in multiple states, occurs across 1.5 million patient encounters. And so when we impact that care and not only help our clinicians be better at what they're doing, I really think it impacts, most importantly, the patients and their families. And so that for me has been real purposeful and just been an interest and kept the career exciting and changing. And I think to what David and Andrew spoke about, that becomes a really big focus what you're doing and just continues to be the work that you love to do. So that's been my trajectory and reason why. But again, I still think the practice component is important. And for my role, what I'm doing, it helps me when I'm doing administratively as well.
Can I jump in? We're not going to all of us chime in on every question, but this one, jumping in off of what everybody else has said. So for me, I transitioned from graduate medical education leadership after 14 years as a program director. I then became the DIO for all of you. And then what happened was I started to really think about what we really, and I loved those roles, absolutely. What I started to conceptualize was that what the hospital really needed, and maybe that I had unique skills and could gain more skills, and we can talk about that later, was to be a well-being leader. And so that was my pull. It wasn't really a push out of emergency medicine. In fact, I haven't changed at all the amount of emergency medicine that I work. It's just what I'm doing with my non-clinical time. That is my admin time, was from GME leadership, which is very meaningful, but really routine. And after you've been doing it for a while, becomes it's routine. The creativity and chance to innovate in a different space, in something that was kind of new and fresh, and well-being leadership was what prompted my transition.
Yeah, I'm coming up on my 4th anniversary of being DIO, so I get it. Dr. Dine, did you do anything to prepare yourself for this new position, or did it find you?
Yes, I actually took a Chief Wellness Officer certification course. But before I did that, I pitched it to our new Chief Medical Officer that I could do this, and would he support that, both financially as well as conceptually. And so that's what we did. So a little bit of both.
Great. And for the other panelists, is it similar? Did you sort of do something to prepare yourself for a new position, or did the new position come to you?
I could speak out in my roles. They have somewhat naturally progressed over time. And when the opportunities presented itself and it made sense, I pursued them. I I did seek out some formal education in the spaces that I work in now in regards to operations, and I've gone through courses and trainings. I don't have an MBA or a master's in health management or anything to that extent. I know others probably do, and those are useful. But I honestly have had great mentors along the way. I see one here, Sandy Werner's on the call today, but at Metro Health, who through their guidance helped me throughout my career. And honestly, I think that is what put me on the trajectory towards the roles when they came up and they were natural fits. And I was always encouraged, I know early on when there were opportunities to just go for it, even if you weren't sure. And I think that is good, sound advice. I think oftentimes the extra work, whether it's committee work or work outside the department, in emergency medicine, it's added work, it's actually extra hours. Sometimes it's not paid. But those opportunities and that networking, I think, really pays off long term. And for me, it certainly has through the 10 plus years of career I've had so far in healthcare.
Our physician advisor program was actually started by an EM colleague of mine, and there were a couple of other EM colleagues that had been physician advisors for a year or two prior to me joining the program. So I felt I had really good mentors that gave me really good advice and at least a script to approach the role. Unfortunately, and if I could write the rules myself, I would find some sort of formal program to go through and, to kind of lay the foundation and the groundwork for just having a better recipe, I think, to approach the role. As it turns out, it was mostly trial by fire. Here's the keys to the car, don't crash it, sort of, what happened. But I think, one of the great aspects of emergency medicine is I had the skills to approach the role confidently, and probably just given our unique role in the healthcare system, being the point of entry for most patients in the hospital and being able to interact and know many of the colleagues across different service lines in the health system, I felt like I kind of had the tools. I just needed to kind of work it out on my own. So no formal training, but I thought EM was a great background for what I do.
Dr. King, do you think that any of your skills that you had as when you were practicing emergency medicine clinician, have those been valuable in your new roles? Do you feel like you utilize any of those skills? Have they transitioned with you?
Yeah, like other people said, is you kind of know everybody and get an idea of what everyone else can do. And so that makes it really easy to have those conversations with folks because at least you have met just about anyone in the hospital. I think at some point we've interacted with them. And really, it's interesting the different perspective that you have doing inpatient medicine versus outpatient and seeing what the view is on the receiving side of patients, like after they've been stabilized and come through the ED. So having the 360-degree view of the healthcare system, like through that, and then trying to create systems where people are coming in and then being taken care of and then being referred out and then accepting them as they're being referred out is really interesting. So it gives you even more perspective, but I think like ED clinicians probably do have the best perspective in the hospital about the difficulties of throughput on all ends.
So a question, maybe Dr. Baskin, if you want to start, I have a feeling all four of you may want to chime in on this, is how has this career transition affected your work-life balance? I was sent an article today from Becker's Hospital Review, specialties with the highest rates of happiness and balance. And so physicians were asked, can doctors in your specialty be happy and well balanced? And they surveyed 29 specialties. And I think you can guess where emergency medicine ranked. 29 out of 29. So I do think all of you, I would love to hear from all of you. I'll start with Dr. Baskin. Like, how has this transition affected your work-life balance or happiness, satisfaction with your job?
I think net positive. That'd be, I think, my overall 10,000 foot view of the administrative non-clinical side of work I do. And I think it's not for everyone. It's personally worked well for me. There are parts of emergency medicine that are great in that you go in and you do your shift, you see your patients clinically, and you're done. There's also extremely stressful parts of that being a full-time job every day that you go to work. And so having the balance of an alternative type of work that oftentimes has different skill sets that emergency medicine builds us great to do, but is different, whether it's business or operations or development type projects we do. And it's very separate from seeing patients in the emergency department, although being prepared to brainstorm and deal with anything on our feet as emergency medicine has trained us to do, we're in a good spot when we reach that position. From a work-life balance standpoint with family, I'm a father, I have two kids at home, a household, like many others probably do that they're managing. I do think the administrative work that tends to fall during business hours is a nice part of this. The only side step I would say to that is I balance that currently with some clinical roles. And so non-clinicians and clinicians that work, which is a lot of physicians, daytime business hours, want to meet during daytime business hours. And so you work a late night shift and you might have to be at a meeting early in the morning. And I think that the roles in administrative work that many of us on here are speaking about really encompass 7 days a week at times, 24/7, 365. So there's a balancing act to that in the modern post-COVID era that everything's virtual. There's a balancing act to that too, where meetings can happen anytime, any day, any time of the week, phone calls. There's kind of an expectation in American work life, I think, that you're on call 100% of the time, even when we're on vacation. That comes again with a different set of barriers that clinical emergency medicine has a nice part of turn on, turn off. But for me personally, and I think for other emergency physicians, the balance pays off. At least that's how I view it. And again, leads to this alternative work that allows, and personally, in my opinion, my clinical work to be better. And I think will lead to a longer clinical work span for me over 30, 40 years.
Dr. Barnes, did you want to comment?
Yeah, at the risk of sounding too enthusiastic, I'm way happier now. They say variety is the spice of life, and I think it's true when you can capitalize on your professional interests and your skill set, and really parlay that into things that are productive and valuable and bring you lots of joy and satisfaction, I think that's a big win. Right now, about 40% of my time is spent in clinical medicine. About 25% of my time is spent as a physician advisor. And the balance of my time is spent teaching. I do consulting editing for AHRQ. I'm on our clinical operations team. I direct our sustainability and I'm director of faculty development. So I dip my toes into a lot of different pieces of admin, education, operations, and it's great. I enjoy it. I feel like I'm balanced. I probably work as much as, well, maybe not as much as I did as a program director, but I certainly work a lot, but I don't feel as overwhelmed as I did when everything was in one single bucket. So I would say on balance, I'm much happier.
I'll go ahead and jump in. I have to say, I'm exactly what David just said is that the wonderful thing about being in GME leadership, whether it's as a program director or as a DIO, is that you have these wonderful relationships with the trainees. And that happens on a 24/7, 365 kind of always on call, exactly what Brian was saying. And so I don't have nearly as much of that now. And so that, while hard to give up or conceptualize giving up at the time, it's been a good transition. Some of that also has to do with the post-COVID, meetings are mostly virtual still, and I can really set my own schedule around the meetings that I lead and chair. And so I'm a little bit more in control. And also I'm just older and I'm in a different place in my life. And my time is much more of my choosing since my kids are grown up and out on their own. So all good. Happy camp. Continue to be a happy camper.
Thank you so much. And Dr. Dine, I was going to ask you also, what do you enjoy most about your current role compared to being an emergency medicine clinician?
Oh gosh. Well, I absolutely love being an emergency medicine clinician at my academic clinical site. Our residents are fantastic. All of you is an amazing place to work because our patients are wonderful. And I am so grateful to have been an attending for nearly 30 years at the same shop, and I just love it. But I also really love being an agitator. So my role as a wellness leader is to be a little bit of a disruptor, but use the skills that I have honed in middle management, which I really honed as a DIO, to really understand what's happening in the C-suite and what's happening in the rank and file, which I very much think being an emergency physician helps a lot with, because I know how the place works and I've been around this shop a long time, so I have a lot of street cred. And so that I think it all works together. Continuing to have that face validity, that street cred of working in the ER, talking to other attendings and residents and everybody all the time in the ED, and then standing there at service chiefs meeting, explaining the new program that I'm creating and how it's going to benefit their attendings it all really is synergistic.
And Dr. King, what do you enjoy most about your current role as compared to being an emergency medicine clinician?
I think working as a ED clinician for me was tough because, we have such weird schedules when you're like working till 3 a.m. and then you can either try to wake up and be with the rest of the world or not, or try to take care of kids, or like you have a random, I don't know, Tuesday morning off and none of your friends are off and you don't have any hobbies or anything like that, becomes lonely time. And so you just fill it up with work. And so it becomes really easy to slip into 24/7 work. And that wasn't a great balance. And I see a lot of people who have the academic dual career things is if you're not working and there's no one else around, like you might as well keep working. So that wasn't like a nice balance in general because of the shift change, et cetera. It was hard to have a hobby or have appropriate me time. But so since then, I've really enjoyed like the 9 to 5, Monday through Friday, 1 or 2 weekends per month, but at least it's like a consistency pattern for me, which has been really helpful. And I didn't really realize like how much of my life I spent just feeling consistently jet lagged or like without appropriate amount of sleep, especially like when we started having kids. And then when you finally get consistent sleep, it's like it very much changes the way that you think and your outlook in life, et cetera. And then being able to make the separation between like when I'm at home, I'm at home, and when I'm at work, I'm at work, instead of having this bleed over, which got really bad during COVID, plus just the way that the EM is set up. So I'm going to be a little bit more of a downer and give some colorful contrast, I think, between my experience and others, if that's okay.
Any of the other panelists want to comment?
For me, I think it was the novelty. I think if you do anything long enough, it kind of gets stale. It's routine, as Pam said. And I've always seen emergency medicine as we're problem solvers, right? Whether it's access or a sick patient that no one else knows what's wrong with them. how do I fix this problem that's in front of me? And you do that long enough, it's, oh my gosh, what about a new problem? How can I have this passion and this drive to solve more problems? But if I've solved the same problem over and over again, it kind of gets old. And so having new problems across different parts of the health system has sort of reinvigorated my interest, and I just feel re-engaged. So it's really about seeing new things and new experiences and working in a different environment that's kind of driven me.
Yeah, and I would kind of ditto to David. The things that I get to do now in the administrative work, the people I get to meet with outside of the department in our or outside of emergency medicine in general, nationally, internationally, business portions of it, consulting portions of it. I think if I went back to when I was in school, I never would have imagined, even post residency, having that opportunity. Certainly in the field of emergency medicine, did not expect that to be part of the job I would have one day. And it has been a really nice fulfillment for a career to have those opportunities. And I can't, even the opportunities I've had in the last year, I didn't imagine last year I would have them 365 days later. And I think for our specialty, we are great thinkers, creators. We see all aspects of the House of Medicine in our departments, in the emergency department, through the specialties, through the lenses of our patients, their access, etc. So when we are at the table with the healthcare system, it's very important. I know we all know that on this call, but it also, I think, is very fruitful from a career perspective personally to represent our specialty in that way. And so I found it very beneficial, the administrative work or the non-clinical work portion of this part of my career.
I'm not going to direct this at any of you particularly, and maybe none of you want to answer this question, but we were asked, how has this change affected your financial situation? Positive, negative, neutral? I don't know if any of you feel comfortable talking about that.
I can go first. For me, it's very neutral. Honestly, it hasn't really shifted it one way or the other. I guess that's a positive. I think many times emergency medicine clinically can be fairly well compensated in the clinical sense. Depends by market and payer situation, how groups are arranged. But for me, it's been very neutral. I don't think it's been less hours, to be just honest. And what I do, I think probably it's more, to be honest. We kind of view some administrative work, it's not less stressful, but in some sense, 10 hours in emergency department that we all know what that's, or 12 hours in emergency department, or 6 for that matter. It's a lot of stress, it's a lot of strain. Whereas in an office setting, it's stress and strain, but it's different. So I think we look at those extra hours as an okay part of the administrative work. And to Andrew's point, you don't want that to become, there is a balance there that can be consuming at times. But from a financial standpoint, in our market, and again, I'm in Cleveland, this is about neutral.
Neutral for me as well. My FTE for a physician advisor comes directly from the health system. It's not a departmental role. Health system pays the department. I bought down the equivalent clinical hours of 0.25, and I show up and do my work. So it's neutral for me as well.
Yeah, same for me. Totally neutral.
Again, to offer a colorful contrast, I am paying for my increased happiness. I'll put it that way.
Is it worth it?
Very much so.
Is there anything that you all miss about working more clinically in the emergency department, or is everyone like, no, this was absolutely the right decision for me to work less clinically? Dr. Barnes?
I think I've struck the perfect balance. I feel like there's a possibility of working too little clinically. I think it's possible to erode your skill set if you're not seeing enough patients, if you're not seeing enough variety of cases. I think it is possible to be less skilled as an EP. And I think I've struck the right balance where I work just enough that I feel fulfilled. I feel my skills are maintained, but I'm not, well, I shouldn't say I'm not burned out. Certainly, there are some shifts where I'm just absolutely fried. But at the end of the month, I can reset. And if I go into a long stretch of PA work in the hospital, which I'm not sure if I said this, it is kind of like a 7 to 5 role. So it is business hours, and we only take weekends if we're taking extra call shifts as PAs. It really is kind of banker's hours. I can reset, I can refresh, and I come back when it's time to work clinically again, and I'm ready to go. Yeah, I think I've found a good balance. So I don't miss anything really.
If I asked my spouse, she would say that her favorite year of my career was the year I did no administrative work. So that may be contrary to this webinar, but it was simply for the simplicity of I went in and worked my clinical shifts and I came home, and that I was on and I was off, and my email, my inbox, my phone calls, my texts were marginal, frankly, to what they are now. I had a year in between some a role at the hospital system I was at prior, where I was in a administrative role, partially there clinically as well, where I moved to a full clinical role for 1 year and then progressed again towards administrative work just sort of feeling it out. But to be frank, it was where I was pulled and I wanted to be. And naturally, no one forced me that direction. I wanted to go that direction. But that would be looking back at it, there is that on-off part of emergency medicine. I think many amongst us in our field want to be that on-off clinician. They want to be 100% clinical, and they're the greatest among us clinically, and we need them in our field. And that part of it is nice. Obviously, we talked about some of the benefits of moving forward, but I think my wife would be a good standard bearer of that call, because that on-off part I do miss.
And Dr. Dine, is there anything like any resources or network or anything that helped you kind of make this transition into your newest role after the GME and DIO?
Yeah, so for my transition from GME leadership to well-being leadership happened kind of at the first couple of years of the pandemic, when I actually got really interested in it from a personal development standpoint and sought training to become a certified coach, life coach. And so I did that training, and through that training of becoming a coach and then working, it's just sort of as a very part-time doing some coaching, I became a part of a whole group of physicians who have become coaches. And this network really just lifted me up. And it was sort of like when I was president of CORD or on the board of CORD, and like this whole group of people just like really, we created something together, and it was really fun. And so it was with that energy that I also became a kind of a well-being leadership concept. And that's when I chose to pursue well-being leadership and took the Chief Wellness Officer certification course that I took. And so I very much stand on the shoulders of other physician coaches and well-being leaders around the country who I've become aware of and have met at various networking opportunities.
And then for those that are listening, please, if you have any questions, put them in the chat and we'll open it up to the group. My last question for the panelists, I'm hoping each of you can answer, is I'm guessing that a lot of people that are on this call live or that'll be listening to this later are considering maybe decreasing their clinical time and doing something else. Do you have any just general advice for them? Words of wisdom, anything that I didn't ask you about that you want to talk about? And start with Dr. Baskin, since you're the one unmuted, the only one.
Yeah, before I even answer that, I was going to default to Dr. Dine's answer. Along the way, I've had these opportunities just presented, and people ask, do you want to be part of this project or join this group, or do you want to come to this meeting? Can you help us out with this or that? Can't say enough about how that opportunity has led to the next opportunity. The mentorship I had through my prior hospitals I worked with, and the current, those mentors, they make the difference. I really think that's the truth. And they put you in the places and in the contact and empower you to make the changes that lead to the next step. So that's been my secret sauce. I have partaken in some educational portion through the American Association of Physician Leadership. They have some courses on leadership and business and other skill sets that have helped too in the things I do in operations and quality and safety and patient experience. And then internally inside my organization, which is Cleveland Clinic, currently we have internal leadership and training courses that different leaders in our organization go through, and those have been really helpful for my track and development. But the connections, I think, and being engaged in those projects and groups and meetings, that's why you get the call for the next project meeting or task, and that's why you get the call for the next role. And when you interview the people at the table, or they're asking you to interview for those spots, take those opportunities when they come up. To the point about advice, I think that was the question. Yeah, maybe to the advice of how to go forward. For me, this was my interest, and it sounds like all the panelists here really have their different interests, their different calling, and I would not want to do this work if it wasn't interesting to me. I think it would be not fun. It would, I don't want to call it painful, but it would be, I don't look at what I'm doing now administratively. It's work, definitely. And I'd much rather be on vacation, but I look at it as, it's positively professionally beneficial to me, and it's interesting. It's academic, it's enlightening. I'm growing through it. I'm learning, I'm becoming a better physician, a better person. And so that motivates me and keeps me going. I think each of us and those on the call and who watch this afterwards probably have our own interests, whatever it is, whether it's emergency medicine based or it's some subset of that or some connection to the healthcare system or patients or whatever it might be. If you follow that, I think you're in a better place. I do see a lot now of people that just want to be administrative and they want to be in leadership roles, and that's great. And I think it has to make sense though, and fit your skill set and be a desire and interest that you want to have. Otherwise, the work could become not something that's going to be interesting, and honestly probably it won't be super successful for that person individually. It sounds like each of us on this group, we have our different interests that we pursued, and I think that is a key to moving forward. And again, accessing those mentors and taking those opportunities when they come up helps advance you towards the administrative state. I would recommend it. Sounds like my fellow panelists would too. I think it's been very beneficial from a lifestyle standpoint, but also just from a professional growth standpoint. So.
Thank you so much. Dr. Barnes, I'm going to ask you next if you have any words of wisdom, advice.
Yeah, I had to quickly sketch some things down so I didn't forget them. So I think first is recognizing that we have a really strong skill set in emergency medicine that makes us valuable assets to any healthcare system. And we're in high demand. People want problem solvers, whether it's administrative, operational, other pieces of the healthcare system. I think they look to EM physicians as people who are going to be problem solvers and be value added rather than risk. But along the same lines, you have to know your own strengths and what it is that you want. And if you're looking, for example, to get into an administrative role because you're burned out in EM, that's not a panacea. I still think you need to recognize that, okay, maybe you want to do administration, or maybe you want to do operations, or maybe you want to do GME, or maybe you want to do wellness. Don't just do something for the sake of getting out of clinical emergency medicine. My second piece of advice is be curious. There's so much out there. I had no idea there were other opportunities out there until I started looking and just being curious and asking my colleagues, like, what are some of the things that I could do? Leaning on friends, leaning on colleagues, and looking elsewhere and getting a sense of the landscape, I think is a good place to start. And the last thing I'll say is don't be afraid to try things and experiment. You don't have to commit yourself to a lifetime of being a medical director or a DIO or anything like that. Certainly, those are big commitments, but I dabbled as a medical director for about 2 years, and I realized I didn't have it in me to continue along that pathway. I transitioned out, and I've found a balance that's working for me.
Thank you so much. Dr. King?
I hang out with a lot of psychiatrists now. You can imagine like my new roles. And so I'd ask people to be curious. I heard someone say that too, is like, what is making you interested in not being an emergency physician anymore? Are you feeling burnt out? Are you morally injured? Are you just not an emergency physician, right? Like, is it just not your identity? And we weren't able to accept that for a long time, right? Like you're struggling with truly like what kind of or aspect of medicine that you want to have. And I think it's reasonable to just start having that conversation because I think you're probably not alone. And then being able to find supportive people that you can work that out because it can take a while to really identify what some of the motivations are and the drivers of the unhappiness. I looked at that article that you just talked about, the specialties with the highest rate of happiness and balance. And so, yeah, we are dead last, just below infectious disease, which I found interesting. And then number one, I'm not surprised, is allergy and immunology. And so when you compare those kinds of specialties, like you want to ask, like, where is the rub? Like, where's the pain? And I think it's worthwhile because you can't really fix a problem unless you measure it. And the best way to measure it is do some deep conversation, have conversations with people that are closest to you and around you to really identify what the problem is and go for there.
Thank you. I don't have any other questions myself for the panelists. Do any of the folks, I haven't seen anything in the chat either. Does anybody that's listening have any questions for any of our panelists or a general question for all of them? Dr. Char?
Yeah, thanks all for joining on the panel. All of you have, other than maybe Andy, have really sort of moved into tangential fields to emergency medicine, whether that's GME, QI, those kind of things. Does anybody know of anybody who's actually truly left medicine or is doing something purely different? So they're not dabbling in emergency medicine and they've truly transitioned to something else?
A grad in my program from maybe 10 or 12 years ago, he actually just started a personal training business, completely left working as a physician and started it. I think it's pretty cool.
Yeah. So the only one that I know is someone at our shop who is relatively new there is now the new CMO for our health system, Chris Miller, who's an EM doc, who was in Cleveland previously at University Hospital, who's president there and is EM director there. And he does like 2 shifts a month. And he actually says it's his sanity break from the C-suite. And it's always funny because the other day we had a SIM that involved a crashing OB patient with post-delivery hemorrhage. I was in our psych area in the back of the ED, and I get paged by Chris going, "Can you come up and play with the sim? Because I'm really not comfortable doing this." But I've talked to him about what led him to go in that direction, and he said it was really just sort of growth and an extension And it sounds like for a lot of you have similar journeys, that this was an opportunity and just a growth, but it's often sort of tangential to EM versus totally leaving medicine and leaving what you've been doing.
Grad from our program I trained in the program that I led and that I still work at. And 2 years before me, a graduate practiced EM for 2 years and then quit medicine, got his real estate license, and now sells houses. That's about as far away from EM as I know any of our grads have been.
Yeah, Dr. Char, I know quite a few actually in our organization that we sort of call it up and out, but they end up transitioning completely out into industry, semi-related to healthcare. But, and then I'll tell an extreme EM doc story, but they typically move into sort of C-suite jobs, whether it's good colleague and mentor at the clinic, is now a chief quality officer for healthcare system in New York City, does not work in the ED anymore and oversees the entire system. Duly had a similar colleague go into that role for an insurance agency company based out of the East Coast, and they're their quality officer for the insurance company. And another go into insurance review, effectively sort of the big bad wolves that we think of in healthcare, but the other side of that field, looking at denials for insurance companies and efficiencies. We have quite a few that go into R&D as well and end up in industry. Some stay internal to our organization because we have a decent research and development here, and we're working on product design, and now it's a tech space is big and AI, et cetera. But some of that have moved on to industry jobs as well. In our own organization, we have similar positions that sort of transition out of complete clinical work towards avenues of research and development, business opportunities, strategy that right now in my current role, we're linked into with those groups, but that is not my primary job right now. Obviously, we have expertise, and those are both sometimes ex-physicians that working in paired with, strictly business folks. The most extreme story I know is we had an EM doc 3 years ago leave. He said he wanted to hike the Pacific Rim Trail for 6 months, and he is still hiking as of today. That sounds like a beautiful story. I'm not in a position demographically with children in the house to go do that, but it sounds like a beautiful way to transition to a different career in the mountains. But I would say, I think, and David pointed this out, and I think we all know this on this call, the skill set in emergency medicine is so broad, and we are problem solvers that have to solve things in seconds or minutes. And that is very transferable, I think. And honestly, in my organization, I think it's been identified as a strength, and we're called to the table to try to brainstorm solutions across the systems. I think those that came before me in this field that set us up for where we are in 2025. But I think the skill set transitions to many other places for those that are interested.
Now you got me thinking of all my program grads who are not doing clinical anymore. There's actually quite a lot of them. CMOs. I was residency classmates with the great Mel Herbert, who has not worked clinically in a really long time, but is such a big part of our specialty, right? In a different way. There's just so many great people who've left clinical practice to do really amazing things for themselves and for the specialty and for medicine and for whatever else that they're doing.
Dr. Kwan, did you have a question?
Yeah, thanks for this wonderful panel. And I think I'm going to try to put this into some cohesive thoughts. So bear with me. But I think everybody brought up so many great points. And I think it's so relevant, Dr. Dine, that you're involved in wellness, because a lot of this does have to do with wellness. And you hear all these reports of people leaving emergency medicine, having the highest burnout rate out of all the specialties. And a lot of it is like really discerning. And I think everybody made some great points about really, and I say this to our own faculty here, and I always worry about burnout in our faculty about, not trying to do something just to get the protected time, because if it's not your passion, like you're not going to succeed, but find your passion, and then maybe the protected time will follow. So I think these conversations are so important and is part of the heart of the faculty development committee. And even things like, we know it's a very, very physical job to be clinical. So as you get older, it becomes harder to do. So how do we find pathways? And that's one of the sub-objectives of one of the subcommittees. So those were some long thoughts. And then my question is, how, for all of you, how important was, you told us of your journeys, but like the networking piece of that, and what advice would you give to people early in their career regarding how to do it and how important it is? And that's for anybody to answer, for all of you.
Yeah, sure, I can cover it. The networking part, I think, is key for the mentorships you can gain. Mine were in the quality safety operations space, and that led me to where I am. I had interest in it, so I sought them out, and they enabled me to the place I am today. But I also think taking some risks occasionally is critical too. I took a risk actually leaving the prior healthcare system I was at, not actually thinking I wanted to do it, just because I wanted to try something new. It with the thought I would go back, and maybe I will in the future. But it has led to opportunities that I did not think would come my way from doing that. And at the time it felt very risky, and I was nervous about it. But honestly, it's been very fruitful, and it's not something I anticipated. So there's risk involved with it too that you have to take at times. There's things you have to pass on to when it's not the right moment for you personally. And then I think, again, to what we spoke to before, if you're pursuing where you want to go, that it's a natural pool and it becomes easier and it becomes interesting as you pursue that pathway. But getting to know different people and networking can't be underestimated, especially in a virtual world. In person as well makes a big difference. And I'm sure we can each relate to this, but I know in my operations and quality work, my networking outside of even emergency medicine throughout our healthcare system just makes picking up the phone and making a call very much easier to solve solutions that are simple, that sometimes get barriers placed through emails and phone calls and people that don't know each other. And that networking definitely leads to the opportunities, whether it's roles and projects or meetings or future positions, that people know who you are, they know what you embody and the type of work you put forward, and why they would want you to come forward for those roles. And if you don't put yourself out there and put yourself in a position to have those experiences, it doesn't just come along and happen spontaneously. So, and again, the mentors are what bring that forward for me.
I leaned heavily on my mentors when I decided that it was time to transition to something new. And, a good mentor doesn't tell you what to do. They help you walk that journey so you can find the real reasons and articulate why you want to make that change. So that was really helpful for me. And then once I got into this new role, leaning on my colleagues who are also physician advisors, and they span the gamut. There's 3 of us or 4 of us that are emergency physicians. There's a cardiologist, there's a pediatric surgeon, there's 2 or 3 internists, there's a psychiatrist. So, it's a smattering of people across different specialties, but they each bring something different to the table and they each have different skill sets. And so leaning on them when there's a new problem that I haven't seen before has been especially helpful. And we meet and talk about the different issues that we face as a group once a month. And that's been really impactful for me. And it's made it very rewarding to have a close-knit group of people that I can lean on for support.
I want to add that I absolutely love going to national conferences and meeting people and networking, and it's been tremendously transformative for my career over the span when I was an APD, then I was a PD, et cetera, and a DIO, and now in my role in faculty development and well-being leadership as well. But it comes at a price, right? Like traveling to conferences takes time away from your family. And that isn't really like, I actually had to take about a 10-year break from doing that at a particular moment when my kids were at a certain age where I just I can't do this right now. I need to be home more. I want to be part of my family functioning when I'm not working clinically. And I'm really glad that I took that break from it so that I could, and now, as I've said, my kids are grown up and I don't have to, my time is very much my own. And so I can jump back in. And I think taking that break also was both for my own head and for the functioning of my family, very important. So while networking is really important, and I will continue to shout that and sing its praises and the value add, be aware of the price it takes and weigh, shared decision making, so to speak.
Thank you. Okay. Well, thank you all so much. Thank you, especially to the panelists for being here this afternoon, and for those that are on this call live, and for those that are listening to the recording in the future. I hope this is really helpful. And thank you to SAEM for helping to organize this and host this. And I hope everyone has a good rest of the day. Thanks, everybody.
Thank you.